Hello, we are honored to host a distinguished guest who has truly transformed the landscape of interventional cardiology in India. Dr. Vithala Surya Prakasa Rao is a renowned interventional cardiologist and a pioneer in bringing advanced CTO PCI techniques to our country. His dedication to excellence and innovation has not only elevated patient care, he also inspired and trained hundreds of fellow cardiologists across India in CTO PCI technique. Join in as we delve into his inspiring journey, the future of CTO PCI in India, and the groundbreaking work that continues to take shape in the field of interventional cardiology. Welcome to the podcast, Dr. Rao. Dr. Rao, I would like to start the podcast with a basic question. Please explain what CTO PCI is, perhaps in simple terms for our viewers.
Our heart is mainly supplied by three arteries. They are called coronary arteries. On the right side, this is called right coronary artery. And the left side, there are two arteries. One is called LAD, next is left circumflex. So, when blood supply goes smoothly in these arteries, our heart muscle works nicely. When there is any block due to cholesterol, then if crosses around 70% or more, then on walking you will get what is called angina, that is the heart pain. Right. Okay, if it is blocked 100%, suddenly you get a heart attack, simple. What happens sometimes is silently you may get a block growing slowly without your knowledge, and it may be seen on routine test. So, if it is 100% blocked artery, more than 3 months, by our definition we call it as a chronic total occlusion, CTO. CTO means C stands for chronic, T means total, O means occlusion, CTO. So, these blocks are different from our routine blocks. You see, the routine cholesterol block, what happens is you can pass a wire, you can pass a balloon, you can stent it easily. Easily means not with much effort you can do. It is a routine angioplasty. But in a CTO, what happens? This hard block filled by lot of fibrous tissue, lot of calcium. It becomes very hard. So, on the angiogram, you do not see any channel also. From the proximal end, you see a stump. In the distal end, there is another stump. In between is totally you do not see anything. So, to create a channel and stent it needs expertise. So, that is why these CTOs mostly are seen in a routine examination. Sometimes patients can present with angina on walking, and sometimes in routine test when you do treadmill test, or after treadmill is positive, or a CT angio, or a routine conventional angio, you see these CTOs. So, these CTOs, how the distal segment below the block is filled is by some fine collaterals coming from the above, or from collaterals from the left side, which is a normal or a diseased artery, that is called donor artery. So, other artery can give blood supply by collaterals by nature, but remember these small collaterals feeding the distal vessel only support during rest. When you do exercise, they will not support the heart muscle, that is why the TMT is positive. When you work hard, when you walk, when you run, that is what we do in the treadmill test, the heart rate increases. Then the blood supply to the distal segment is not sufficient by the simple collaterals. So, we need to open the artery from above, create a channel and put a stent, improve the blood supply in a natural way. This is the CTO.
From my understanding, CTO PCI is a complex, non surgical interventional procedure used to open completely blocked arteries for over a period of time. Is there any specific criteria to determine eligibility for this procedure?
That is a very good question, because we see these chronic total occlusions in 25 to 30% of our routine angiograms. Now, the number has increased because the awareness also increased. That means we do 100 angiograms, 25% will have chronic total occlusions. Whether we should treat all these blocks is a very important question, because If the artery is very big, supplying a large territory in the heart muscle, and that muscle is very viable, means they are all living cells in the muscle, and the patient is symptomatic, there is no doubt you have to open the artery. Why? Because it helps the patient to get relief of his symptoms, that is what is called angina. And also if the muscle function is less, if it is viable, we see viable means it is not all looking scarred muscle, dead cells is not dead. We have some methods like we do a perfusion scan, what is called perfusion scan, by giving a isotope scan, then what is called cardiac MRI. We look at a different test like a dobutamine stress echo. These are all the various tests to determine whether patient gets the benefit or not. So, patient's muscle is viable and a very big artery is occluded, patient is symptomatic, there is no doubt we should do the CTO PCI. There are borderline cases where the artery size is not that much and patient symptoms are vague, and we go through different battery of tests to determine whether our procedure helps the patient or not. Third important thing is there is always the anatomy. The anatomy of the artery which is blocked carries risk during procedure. We have different scores. There are very many scores like Japanese have formed, Europe has formed, US has formed, and they combinedly this is called algorithms. Fortunately, I can proudly say that I am also part of the others who have in the world literature written this one of these algorithms when to do the CTO PCI. This is in borderline cases, we take all these scores and calculate and see that patient gets benefit. Benefit means relief of his symptoms, relief of his ischemia, that is blood supply is improved, relief of his arrhythmias, irregular heart beating control, and heart failure. He improves from the heart failure and overall quality of life. These are all important when we do a CTO PCI.
We have seen you speak on social media and television about how CTO PCI can be a real blessing to certain groups of people with blockages, such as young or very elderly patients. Could you explain how CTO PCI can benefit these specific groups?
Yes, with a lot of experience of my own and also going through the different trials in the entire world, registries, what we call registries, randomized trials and all. The CTO PCI is initially we thought it will benefit very old people who cannot tolerate the major surgeries, bypass surgery, and those need a percutaneous procedures without much trauma, blood loss and injury. And also the young people, you see at 30 years age you subject somebody for a bypass surgery, then he will be psychologically down and demoralized, and he feels that he may not be selected for the jobs, he has to get married, he has to beget children. There are many issues in this. So, these are the two groups initially focused on the CTO PCI, that patients should be get benefit by doing a non-surgical method either from the groin or from the wrist in a sutureless technique. But over a period this technology improved, the techniques improved, the skills improved, and many proctors like I proctor in many states in India and abroad, and the Japanese proctored India when we started this program in 2006.
I believe many of us are familiar with the cardiac intervention procedures like angioplasty and stenting, which treat blockages in the heart. Could you explain how a CTO procedure differs from these?
You see, in India and abroad also, now the angioplasty procedure became a routine non-surgical method to treat the blocks in the coronary artery. Even at district levels, in Taluka headquarters, you see many cath labs coming and many of the cardiologists performing these procedures, because there is a channel. If you see, the occlusion site is 70%, 80%, 90%. You have a channel for the wire to pass. The first step in angioplasty is to pass a very low profile, we call it a 0.14 inch wire to pass through the block and dilate with a balloon, suitable balloon. The balloon expands and expands the channel and creates a path to stent to negotiate into that. So, then the stent gets expanded with inflation techniques. So, this is a routine process. In CTO PCI, what happens is there is proximally there is a entry point, distally there is a exit point. In between you do not see anything on the angiogram. Then how the distal vessel is filling? The distally the vessel is filling by help from the collaterals. We call it them as collaterals. There are very few microns of vessels which fill the distal segment from the other side of the artery, like right side vessel is blocked. Then how the distal vessel of the right coronary is supplied from the collateral from the left system. This is God and nature has provided beautiful collaterals not to have acute problem, but they are not sufficient when they do exercise. So, they are at rest, they are okay. When they do exercise, they get symptoms, they get complications. That is why it has to be opened. So, when you opening these hard blocks which has full of calcium, fibrous tissue to navigate, we need very advanced wires. The Japanese have fashioned and innovated many beautiful wires from different companies, and these can navigate the hard channel from it should enter the correct channel, true lumen, what we call true lumen in our cardiology. It should enter proximally in the true lumen, distal in the true lumen. There are different techniques, technologies which we will discuss, and after that the very low profile balloons. You will be surprised to hear there is balloon which is less than 1 millimeter available. So, with that balloons we dilate and we see with many gadgets and stent them. So, it is a totally a different type of skilled procedure performed by a skilled operator.
Dr. Rao, you have worked extensively over the years alongside pioneering Japanese cardiologists, and now you are serving as a proctor, training fellow cardiologists globally with your dedication and expertise, which is truly inspiring. We would be honored to hear more about your remarkable journey with Japanese colleagues in mastering the CTO PCI procedure.
Yes, I am fortunate to say that I have a lot of collaboration, association, friendship with Japanese cardiologists who are masters in this particular area of CTO PCI. Later it has spread to the Asia and Europe and US. And from 2006 I got association, almost now it is 20 years association with the Japanese, and our initial rates of CTO PCI success is just around 80%. Now the Japanese touched 95, we also touched almost more than 90% with advanced techniques. Fully express my gratitude to those Japanese, but it is a mutual interaction. Now we see what we got is more number of patients with more disease. As you know, India is a diabetic hub in the world. We have very hard blocks, calcific blocks, and second thing is people do not want surgery. Anybody usually see percutaneous procedures people prefer, and even we as cardiologists we try to prefer a non-invasive simple techniques to treat these blocks. And my journey started in 2006 when we formed what is called a organization called CACTO. This is a complex angioplasty and CTO program. We started in Hyderabad, Telangana. That is very important, the initial first program, and many Japanese colleagues from Europe and US attended this program with more than 350 delegates came to India. I organized this program with my team members, and many of my team members really done great job in this. And then we started every year doing this program in Hyderabad, and in 2009 many cardiologists we have got Dr. Saito, Dr. Chai, Dr. Nasu, Yamane, Sochikeni, they are to tell, they are all topmost cardiologists in Japan. They used to visit these our centers and we used to visit the Japanese centers for interaction. So, in 2012, it's a very nice that I spread this message of CTO PCI to pan India. So, I invited many course directors from different cities of the India, from Mumbai, from Lucknow, from Cochin and Delhi. Many of them joined this, and we formed what is called a Indo-Japanese CTO club. This is called IJCTO. If you go to the website, and this has now become the one of the largest program of CTO PCI in Asia, giving training to many fellows, bringing advanced tools to India, involved in indigenous products of CTO PCI, and we have an association with the Japanese forums, what is called the CTO club, which is there in Nagoya in Japan. The IJCTO has got sessions officially, and this is a great privilege and really great news for all Indian cardiologists and Indians, that the Indian cardiologists are able to get associated with Japanese now doing an equally on par with the Japanese with advanced techniques and outcomes touching 95%. This is our association.
I believe you have been awarded the prestigious title Sensei by Japanese cardiologists. And what does this recognition mean to you in the journey of mastering CTO PCI technique?
Yes, sensei is nothing that day is like a teacher or a mentor, but when they call me a sensei, I took it as more of a respect and honor and a mutual interaction of with the Japanese cardiologist, and it naturally increases your, it inspires you to do get involved in this technology, more interactions and bringing them back to India, all this technology and helping our people. Some of them are affordable, some of them are non-affordable. Those non-affordable, now we are getting the indigenous products. That's why I always feel proud when they call me sensei.
How significantly is the CTO PCI procedure transforming the treatment of coronary blockages as an alternative to CABG or bypass surgery?
I think last 20 years, a lot of progress happened in the treatment of the coronary artery disease. So, bypass is dominating. Most of the patients used to go for bypass surgeries somewhere in 2004, something like that. After that, there is a lot of advancement in the technology, like the drug coated stents, third generation. So, the drug what is coating the stent has very less thrombosis, clot formation tendency, and very less re-narrowing. This is a big advantage in the percutaneous procedures. And there is another what is called intravascular ultrasound, IVUS, and OCT, optical coherence tomography. These are the techniques of imaging. There are also CT scan. Now, CT scan for the heart, all these devices and the tools, skills improved. So, the transformation from bypass to without bypass is happening. So, as I said, we have a good connection, interaction and association with these Japanese organizations, Japanese cardiologists, and fortunately, I took the lead in the beginning. And what I have done is I have shared this information and technology with many of the Indian cardiologists through different forums, and this made a big change. There are scores formed. What is called scores means what is the risk benefit ratio of doing a procedure. When you always assess what is the risk, what is the benefit. If the risk is less, benefit is more, there we attempt these procedures. So, these scoring systems changed the scenario slowly from I bypass to CTO PCI in selected cases, suitable cases.
Doctor, can you tell us about the common concerns patients express when they have to undergo a CTO procedure, and how do you address them?
Now, the CTO PCI, as I said, in routine angiogram procedure, almost 25% of the cases are having CTO, and the CTO PCI also has increased up to 10% of our routine PCS in India. That means it is growing the number is growing. Number is growing means the success rate also is growing. Patients are happy with the results. That's why it is growing. Very important thing is patients will have their concerns, and the doctors also, not the patients. The doctors, there is always concern for safety and success outcomes. This is very important. In this, what I have seen with what a lot of experience myself had with more than doing 1500 CTO PCI over 20 years, I have seen the if you are doing this procedure in a good resolution cath labs and with all the tools whatever needed for a basic CTO PCI in the shelf, with your supporting systems like good assisting staffs and fellows helping you and anesthesia team. This is called heart team approach. The complication rate is equivalent to routine PCI. There is not much difference. In a very rare unusual cases, if you face untoward thing, we are always geared up to tackle that with the special devices like some coils, snares, we handle it. Very rarely I have sent for patients for a emergency bypass, very rarely. So, it shows not only me, many of the operators in India, many of the centers are doing this PCI with confidence. But as I said, it should be done methodically and with a hot team approach. That is very important.
So expenses wise, how do we, rate this procedure as?
Yes. It's a good question that India, country like India, where definitely economically we are becoming sound, but still cost effectiveness is a very important issue, and a routine angioplasty needs some simple techniques and simple tools. But this CTO PCI needs extra hardware, there is no doubt. We need to do the now in Indian firms, many of the Indian firms are manufacturing indigenous products. That is a very good trend by the central government's initiative, and also the cost of the devices are coming down. Unlike the previous 10 years back, even the imported devices are also coming down, and most of the devices are available in India. That is a very good point. The Indian government has permitted most of the devices which are needed for the CTO PCI. There is a little high cost than the routine PCI, but it is not beyond the affordability of the patients here. And government schemes are also helping and adding up this material in some of the schemes. That is why the number of CTO PCI are going up in India as per our National Interventional Council. We regularly do a data analysis from NIC data. In that, our CTO PCI number has been increasing. It is not all corporate hospitals, there are some government hospitals. I do proctorship in government hospitals.
Based on my understanding, interventional cardiac procedures such as angioplasty and stenting are typically performed in a cath lab by an interventional cardiologist with a team. In the case of CTO PCI, is additional advanced infrastructure and specialized manpower required?
If you ask me that can the CTO PCI can be done in any cath lab, otherwise round, I say no. Because to have the CTO PCI with success rate with no complication or less complication, we need to upgrade our systems. This always I advise that you should have a good cath lab of a very good resolution visibility, and you should be able to do in lowest possible radiation. Like we have a frame 7.5 frame, 15 frame, we have got in the cath labs these systems. We have to possible lowest possible radiation we have to do. This plaque which is very hard plaque, there is no channel, there is no connection between the proximal end and the distal end. We have to connect with advanced tools which are called specialized wires from Japan and many other countries, now in India also. These wires cross this hard block without causing any trauma. After the wire cross, what we have to do is very miniature balloons. There are balloons which are less than 1 millimeter available. And how you track these balloons, sometimes it may go into false track. We call it imaging. This is called intravascular ultrasound. After that, there is a lot of calcium you see in these blocks. The calcium has to be broken into small micro pieces which can get into dissolved into the blood or go into the distal circulation. Then only the stent can deploy nicely. Once the stent is deployed, the whatever the best generation stents, they attach to the endothelial wall of the artery, and it should be expanded fully for a better outcome on the long run. So, you see, and the supporting staff, as I said, not only the cardiologist doing this, you need a good cath lab machine and you need all these tools, imaging systems, and sometimes we need to assess this by what is called CT scan. It assesses nicely how best this case can be done without prolonging much time. And also very important is the anesthetist support. Sometimes we need some support from the anesthesia team and the surgical team. Very rarely, fortunately, there are not many cases we have referred for surgery with acute problems and all, but we should be prepared for when you are doing these complex procedures, and they can be done very safely. That much I can tell. If you take all these precautions together and do the cases, you can do it a very safe procedure.
Doctor, could you please walk me through the step-by-step process of how a CTO PCI procedure is performed from initial assessment to final restoration of blood flow?
This is a very good question, because you see, when we perform the CTO PCI, first of all we should assess whether the patient needs CTO PCI or not. How we know it? The patient has a major artery, very big artery. We consider above 2.25 is usually a good sized vessel, and patient is having symptoms, classical angina, and no other blood vessel is involved, definitely needs a procedure. Sometimes there is a dilemma whether this procedure, which involves some cost, which involves some time sparing by the cardiologist and the family and the patient, and so then we have to study the patient by what is called viability test. That means, if you do the procedure, patient gets benefit or not. These are tested by what is called a cardiac MRI. Usually this is a very gold standard test, and sometimes we do what is called PET CT. We can assess the viable myocardium, how much myocardium we can revive and give benefit on long run. This is important. This can be assessed by what is called a dobutamine stress echo, very simple test in the echo room. All these tests will give you, somebody patient can walk nicely without any problem, we will do a simple treadmill test also. So, this is called what is called a ischemia is there or not. That means, if you relieve this block, the ischemia, whatever the lack of blood supply problem is solved, one thing. Second, in a muscle where you think the muscle is already dead, but there is viable cells which you cannot see on the angiogram. So, we do all these tests like cardiac MRI, PET CT and all those things. Then we will take a decision, this patient needs a procedure. This is important. Next thing is, some cases we need what is called a CT scan also, very important. CT scan also, what happens is the difficult anatomy, like cases by scoring system, this is what is called a JCTO score. The score becomes more, the case is more difficult, challenging, that I get cases which somebody has failed and send the patient for a better outcome, then I have to be more cautious. So, we do what is called a CT scan of the heart and see how the artery, what is the length of the total blocked segment, how much calcium is there, how the branches other from the other side are supplying, and all those information is very much needed, any bends are there. So, all this information is very important before the procedure, like a CT scan. Yes, we have taken up the procedure for a CTO PCI in these cases.
Dr. Rao, how safe is the CTO procedure? How do you make sure patient safety and better outcomes?
Once you enter the CTO, there are 3 techniques what we standardize as per the algorithms. This is internationally formed algorithms by many countries, cardiologists joining together. We have to form this like step 1, step 2, step 3, step 4. What we do? We always try what is called the anti-grade approach. That means from the proximal cap, from where the entry point this is blocked, that point is usually tried to cross with a wire, suitable wire. How is the suitable wire? We choose by our experience and from the data whatever available, without wire, with a support called microcatheter. So, that wire should cross correct true lumen. That is why we use what is called a microcatheter of different companies. With a suitable wire we try to cross it. When we are in the wrong track, it can be guided to a true track by what is called the IVUS imaging, intravascular ultrasound. This is a very miniature camera of 1.25 millimeter tip like this. We can see beautifully whether your wire is in the true lumen or false lumen, then we can track into the correct lumen. After that, what is called the distal cap. So, I said there is a channel which is totally blind. This has a proximal entry point, distal exit point. Now, the problem is crossing the distal point. So, for crossing the distal point, we should know how is the artery size, where to cross, where to puncture with the wire. This is very important. We know by what is called a contralateral injection. That means, we use 2 axes. Suppose we keep one catheter in the femoral artery, we can keep another catheter in the other side of the groin or in the near the wrist. See the other artery which is supplying the blocked artery, we have to inject also. So, this is called simple anti-grade approach. We increase the wire strength one by one. One cross is not wire is not crossing the weak as the second wire. We use the third wire like that until it crosses neatly into the distal true lumen. We try then dilate with a very low profile miniature balloons, then increase the size of the balloons. So, perfect channel is created for stenting. Once its stenting is like any angioplasty, you can stent it and approximate the stent should be opposed to the wall. That is very important for long term outcome. So, the stent is opposed expanded into the blocked segment and to the healthy tissue above and below. So, finally, it is a good result confirmed by the angiogram, by the intravascular ultrasound. Not in every case we do intravascular ultrasound, but usually it comes. Sometimes what happens is we cannot cross the lesion from above because the cap very calcific, we cannot do. So, these cases experienced operators will do from the other side the healthy vessel, what is called the donor artery. So, from the donor artery there are beautiful collaterals which are given by the nature, and these collaterals join the segment below the block of the blocked artery. So, through those small collaterals with special wires and microcatheters, we cross this in a what is called retrograde CTO PCI. This is very advanced technique, needs lot of skill, lot of hardware, and we take all safety precautions and do it. Sometimes there are techniques where only antigrade approach is feasible. We are in a false lumen, we are not into the true lumen. There are beautiful gadgets have come. There are devices which are called recross devices, stingray devices. These are the devices to re-enter into the true lumen from a false lumen. So, many devices from different companies, but they make us enter into the true lumen and form a channel and put the state. So, over this procedure is over. What we have to take precaution is the contrast. We inject some contrast to see every time whether success is correct or not, we are in the correct way or not, all these things. But we have got a formulas where we limit our contrast depending upon the patient's kidney function. This is very important. We always look at that angle, and because the contrast what you use during the procedure can rise little is kidney creatinine function. So, if you take all precautions, usually it is very safe. So, we hydrate these patients nicely, we give good hydration before and after the procedure, so that the kidney functions are well preserved, and we will minimize the contrast. The radiation, all these cath labs carry some radiation, but there are very nice advanced cath labs with, I told that if you do under a very low frame with particular views, then we have different techniques of minimizing the radiation. There are different cath labs which are fully proofed with radiation protection. There are different sheets coming up protecting the patient and doctor from radiation. That is why the radiation issue is not a big one, because all protection is taken during these procedures. But we see to minimize the radiation to below 3 gray, what we usually follow, but some cases can exceed when you are reaching the success, but we take all precautions and close follow up of these patients. With these all precautions, the procedure will be successful, and very important is medication. It is not the just procedure doing all this, patient has to use the blood thinners. Usually give 2 blood thinners, one cholesterol controlling drug most of the patients have. These drugs should be continued, not to have any blood clots inside the stents, not to have a re-narrowing in the stents, and a very good follow up is needed. Fortunately, with a huge volume what I have done last 20 years, I have seen very less incidence of clotting or restenosis in these cases. If you follow up all these techniques and use very advanced tools.
Thank you so much, Dr. Vithala Surya Prakasa Rao, for sharing your invaluable insights and expertise on CTO PCI. Your detailed explanations and experiences have truly enriched our understanding of this complex procedure. We deeply appreciate your time and dedication in advancing international cardiology in India. We look forward to seeing how the future unfolds for CTO PCI, and we are grateful to have had the opportunity to learn from a pioneer like you. Thank you once again.
Thank you so much.